Good evening, everybody. As you're getting your screens up and getting the video, audio going, I'm going to introduce myself, and then Kelly is going to talk to you about lymphoma tonight. I'm the inaugural director of the Riney Cornell Canine Health Center, and our job is to make the lives of dogs and their owners happier. We try and help dogs live longer, healthier lives. And of course, one of the cancers that Kelly's going to talk to about tonight is quite common. And I've known Kelly for a long time. She's a Kentuckian, graduate of Auburn University. She did a medical oncology residency at North Carolina State University. She came to Cornell in 2008, where she did a clinical fellowship. She's been a faculty member since 2010, and she has broad research interests in feline and canine cancer. And her goal in her everyday clinical life is to make treatments for cancer more beneficial for dogs and cats and other species. And she has 3 cats of her own and 1 aging dog. And it's my pleasure to introduce Kelly and let her take charge. Thanks, Kelly.
Thanks, Rory. That was a lovely introduction. I hope everyone can see my slides okay, and presumably my face somewhere. If you have questions or technical difficulties, feel free to post a message in the chat. I will have time for questions at the end, which you can certainly post those in chat, but I am not going to routinely check the chat while I talk for questions. I'll do that at the end. I have my email address up here, and I'll have it on again at the end. But if you have follow-up questions or want to chat about anything, do please feel free to reach out via email. Okay, so that's me. A little delay in the slides advancing. Okay, Ashley, I can't get the slides to advance.
Try using your keyboard.
That is what I used.
Oh. If you toggle over in your PowerPoint view.
I'm going to stop share.
Yep, go ahead and try that again.
They're back.
There you go.
Okay. All right. Sorry about that, folks. I wanted to do my disclosures and acknowledgements first. I don't have any personal financial support or conflicts to disclose. I'm going to talk about some research at the end, so I have where that research support has come from. And certainly in doing the clinical trials, the hospital staff, the clinical trials coordinators, the house officers, the technicians, the owners of the dogs that participated have obviously been really important. And I have my research collaborators listed. And I'm going to talk about Laverdia as a drug used to treat lymphoma. I have a separate study looking at Laverdia and osteosarcoma, and Anaviv does donate drug for that study, but they did not donate any of the Laverdia used in my lymphoma study. And then up in the corner is my dog, Ziva, that Rory mentioned. This picture is 7 years old, and I have a more recent picture at the end. So, you know, when we get to her picture again, I'm ready to stop talking. Okay, so fingers crossed. This is how I have structured the overview for today. I'm going to go through just a bit of a broad overview on canine lymphoma. As an oncologist, we see lots of lymphoma, and I could talk about lymphoma for a really long time, but I'm going to try not to go over an hour. So I'll do a brief overview, or really maybe about 30 minutes of overview, and then talk about the 2 novel therapeutics that are available, Tenovia and Laverdia, and then some of my research related to alternatives to chemotherapy. And some folks are participating for a CE credit, so there's the learning objectives as well. Okay, this dog, her name is Rosebud. She is one of my most favorite lymphoma patients. I treated her when I was years ago, oncology intern at the University of Georgia, and she had lymphoma and ultimately was euthanized for progression in her pancreas. So the 7 things I'm going to go through about lymphoma that I think are important to keep in mind as we approach sort of therapeutic development and think about managing patients is that lymphoma is not one disease. The grade of the lymphoma matters, phenotyping matters. So I'm going to talk a little bit about that. And then oncologists also usually harp a lot about staging. I'll talk a little bit about that. And then I'm going to talk about drugs other than the CHOP chemotherapy protocol, but I want to give just a little bit of reference and background on CHOP as well. Okay, so, the title of the talk says an update on canine lymphoma. And when we talk about dogs having lymphoma or cats having lymphoma, we just use this generic term lymphoma for the most part. But if you look at the WHO classification, there's really 90 different types of lymphoma. So to just say lymphoma isn't really a very defining diagnosis. Within that 90 to 100 types of lymphoma, there's about 60 different types of B-cell lymphoma, 30 different types of T-cell lymphoma. And how you go about figuring which type of lymphoma the patient has involves looking at the morphology of the cells, doing the immunophenotyping, and then also some genetic and molecular testing, as well as thinking about the locations where the lymphoma is and the age of the patient. So, these are classifications for people with lymphoma, and our way of classifying lymphoma in dogs is not nearly as intricate as this, but really we probably have very many of these same classifications. We just don't necessarily have the tools developed to recognize them yet. Okay, so the most recent classification that we have in dogs using the WHO criteria is this publication out of UC Davis that's from 2013. And that WHO classification I showed you counts from the 2022 version. They update it about every 6 years. So there was a 2008, 2016, 2022. This is the most recent classification we have for dogs, and it's 2013. So we're not as good about updating our canine systems. But the things I want to point out on this Kaplan-Meier survival curve are that the pathologists involved here have grouped canine lymphoma into about 7 different categories and then looked at survival. So each line is a different category of canine lymphoma. And I'll just highlight a couple of them. This blue line here that does the best, those dogs with a type of lymphoma called indolent T-zone lymphoma. In the middle, you have dogs with different types of B-cell lymphoma. And then the dogs that don't do nearly as well are the dogs with T-cell lymphoma. So we talk about B being better than T-cell lymphoma, and that holds true in this survival curve, looking at these specific different types of classifications. And then certainly the type of lymphoma in dogs that does the best is the indolent T-zone type. Okay, the first place most people start when thinking about type of lymphoma in dogs is the grade of the lymphoma. And the grade really, as you're used to thinking about with mast cell tumors, soft tissue sarcoma, it's really based on the mitotic index when we think about how to grade lymphoma. And to really do that, you usually need histopath, which we don't always have. But the grade generally correlates with how quickly the disease progresses, and also the size of the cells morphologically. So high-grade lymphomas, high mitotic index, rapid progression, and overall a worse prognosis than what we would think of as a low-grade, more indolent lymphoma. So High-grade lymphomas morphologically are usually very large cells. So because we don't always have histopath, you'll hear me use the term large cell lymphoma, because that's describing the size of the cells on the cytology evaluation. Exceptions to this sort of thinking about grade and disease progression, just to mention them, there are cases where I've seen that the cells are very large, but it's still read out on the biopsy as a low-grade process. And that's because the pathologist is really looking at the mitotic count. And for whatever reason, in that particular patient, there just isn't a high mitotic count. Most of the time, those dogs have clinical high-grade lymphoma in terms of the lymph nodes got big very quickly. Mantle cell lymphoma is a very unique type of lymphoma that I've maybe only seen once or twice, and that is low grade and small cell, but does not seem to have an indolent clinical course. So really, you know, when you're thinking about the patient in front of you, it's important to not just go on your cytology or histopath grading description, but to think about what the clinical progression has been in the patient in front of you. And then there's also this term intermediate grade that, or intermediate size cell that you'll come across. And I don't think that we have enough data to really know if those intermediate grades have a different biologic behavior. So I try to think about, given the rest of what I know about the patient, is it more like a slowly progressive small cell disease or a rapidly progressive large cell disease? And most of the time the description says intermediate to large cell. Okay, so that's sort of the first step of classification, thinking about whether you have a high-grade large cell disease process or a more indolent disease process. The next thing that we think about in terms of classification is the immunophenotype. And like I showed you on those survival curves a few slides ago, knowing whether it's a B cell or T cell process gives us a lot of prognostic information. It also is useful as a diagnostic confirmation and can direct therapy. One of my main missions in life and my resident trainees is really to convince them to always, always, always phenotype lymphoma. So most students on the rotation can answer this question, which one is better or worse? There's the acronym B is better, T is worse, and that holds true. It's important to remember that that's only for dogs, and it's only for high-grade large cell lymphoma, not the indolent varieties, and not in cats. So for B cell lymphoma that we treat with multi-agent chemotherapy, we can get up to 80 to 90% of those dogs sometimes into a remission that can last around 10 to 12 months. And B cell lymphoma is more common than T cell. For T cell, the percent of dogs that obtain a remission is lower, in the 50 to 75% range with multi-agent chemo. And the duration is a bit shorter as well, maybe 6 to 8 months on average. We suspect T cell lymphomas in dogs that are hypercalcemic if they have a mediastinal mass, a GI mass, or a primary liver tumor. And then boxer dogs, certainly T cell lymphoma is a little bit more common than B cell. So even though B is better, that doesn't hold true for every single individual dog. There are some B cell lymphomas that fail early, and one of the things with flow cytometry immunophenotyping that you can just determine is whether the lymphoma cells express MHC2. And here's a paper from 2011 showing that dogs that had high MHC2 expression had a better outcome than dogs with low MHC2 expression. Okay. So how do we figure out the immunophenotype? There's 4 different common ways. And the 2 that most people are familiar with or have been most common over the years are immunohistochemistry and immunocytochemistry. So immuno meaning it's an antibody-based test. Histochemistry is done on fixed tissue, whereas cytochemistry is done on a cytology specimen, but really it's the same antibodies. You're staining the cells for markers of either B cells or T cells. Most large labs and small labs offer IHC for your common B and T cell markers. Immunocytochemistry is a lot less common, and it's a bit more challenging to get a well-validated protocol in the lab. So what we really like to use is flow cytometry. And it's the same sort of principle as immunohistochemistry, but it's done on viable cells from a lymph node aspirate, for example. And there's a lot more markers and antibodies that work with flow cytometry than work with IHC. And that's why we really like to do flow. Because in addition to doing your B and T cell markers, you can look at markers of myeloid cells, which helps you make sure you don't have a leukemia patient. You can look at that MHC2 expression I mentioned. So really just a lot more markers. And most of the big labs nowadays offer flow cytometry as well as IHC. Another thing that some people will try for immunophenotyping is to do PAR, which stands for PCR for antigen receptor rearrangement. And it's not really immunophenotyping because it's a PCR test, not looking at protein expression. You can do this off a cytology or a histology sample. So that's one of the reasons it's often recommended if you only have a cytology sample available. It's offered through a couple of different universities, and I don't honestly know if the labs run it or just send it out to universities. It has about a 70% success rate, meaning sometimes the primers used in the PCR test just don't bind with the sample and you may not get a result. One of the things to be aware of with the PAR is you can't necessarily use it as a diagnostic test for lymphoma because you can have cross-lineage rearrangements. And what I mean by that is the dog could have a B-cell lymphoma, but have rearrangement in its T-cell receptors. So for us, flow cytometry is our first choice. IHC is a good option if you have fixed tissue. And then if all you have available is a cytology specimen, that's usually when PCR is used. Okay, so we want to know the grade, we want to know the phenotype, and then we also are interested in staging. So all the students usually get asked this question on their rotation. It's a nice staging system that goes 1 through 5. It's pretty easy to follow in terms of one lymph node, multiple lymph nodes, both sides of the diaphragm, liver, spleen, and then bone marrow or extranodal sites. The problem with the staging system is that it's really most useful for nodal multicentric lymphoma, not for other forms of lymphoma. And I'll explain that in a second. But really, we want the staging so we can know what sites of disease are involved to help us think about how the patient will handle the chemotherapy, where we need to be monitoring for remission, and to give us some prognostic information. And intuitively, the higher stage disease usually has a worse prognosis. So we think about stage and then substage, whether they're well or whether they're sick. So the staging system is prognostic and it is useful, but it has its limitations. And I'd have 2 examples of those limitations. So if you have the dog on the left that feels great, just has giant lymph nodes, and on ultrasound has evidence of infiltration, normal blood work, infiltration in the liver and spleen, that dog is going to be considered stage 4. You could have a very different clinical presentation where a dog has vomiting, diarrhea, does not have any lymphadenopathy, the bilirubin is high, there's icterus, there's lymphoma in the liver. So that's a sort of very sick dog with a primary hepatic lymphoma. And those 2 disease processes aren't the same, and the biologic behavior isn't the same. They're both going to be called stage 4, though, which is one of the limitations of the staging system. The dog on the left will be substage A, whereas the dog on the right will be substage B. And then kind of similarly, as an example for stage 5 lymphoma, you could have a dog that doesn't have any clinical signs, has big lymph nodes, has normal blood work, but you do a bone marrow aspirate and you find a low level of blast. That's going to be called stage 5. Then you could have another dog, again, that's febrile, anorexic, has lymphadenopathy, has anemia, neutropenia, thrombocytopenia. You do a bone marrow on that dog and you find a high number of blasts, Really, with 50% blast, that might be a leukemia, but you may not be able to rule out stage 5 lymphoma. Again, those two dogs are very different. Their biology of their disease is very different. Our expectations for them are very different, but they're both going to be called stage 5. Again, the one on the left will be substage A, and the one on the right will be substage B. Okay, so when we think about our ability to classify dogs, lymphoma in dogs, again, we think about the grade, the phenotype, and the stage. So for me, when I have a dog with high-grade large cell lymphoma, this is the way I think about it. I think about whether it's T cell, whether it's stage 5, or whether it's substage B, that those dogs are going to be less likely to reach that 12 months, like the B cell dogs. Their median is going to be closer to 6 months. That's thinking about all of those dogs together as a group. There's individual dogs with T cell lymphoma, and I'll give you a case example, that live many years from their diagnosis. And then there's dogs with B cell lymphoma that have all the good prognostic factors and don't make it beyond a few months. So even though we have these different ways to classify and prognosticate, it's still a bit challenging at the individual patient level. Some other exceptions or specific scenarios I wanted to mention. Again, if it's a primary hepatic or a primary GI, and by that I mean that the disease seems mainly in the liver or mainly in the GI tract, not a high proportion in the lymph nodes, those dogs sometimes only get 2 to 3 months with treatment. And then I'm not going to talk about cutaneous lymphoma too much this evening, but that is a difficult disease to treat, has a very variable clinical outcome. Happy to take questions about that later. Okay, so before we switch over to talking about some of the new drugs, I wanted to talk about CHOP chemotherapy for a bit. Hopefully everyone is a little bit familiar with that. C is for cyclophosphamide, H is for doxorubicin, O is for vincristine, and P is for prednisone. And for the most part, we still think about CHOP as our first choice for treating lymphoma in dogs. There are some situations where that's not always the case that I'll highlight. And, you know, there's a lot involved with CHOP chemotherapy. So while it might be best in terms of that's what we have years and years of research and publications on, it doesn't mean it's the best or feasible for an individual family. So the main challenge, I think, for families trying to do CHOP chemotherapy is it's a very intense protocol. It's weekly for about 8 weeks, and then generally every other week for somewhere between another 3 to 6 months. And there's a lot of different types of CHOP chemotherapy out there in terms of the schedule of the drugs, how they're grouped together, but it's all those versions are still pretty intense. There are other protocols that I'll highlight. The other protocols, the things that are nice about them for families, they're less frequent. Because they're less frequent, they're usually less expensive. And again, because it's not quite as intense, overall the toxicity is probably a little bit less. The big con is that when you look at groups of dogs, there's less efficacy. That doesn't mean that for an individual dog, it can't do well on one of the other protocols. Okay, so historically, these are what I have thought about as our alternatives to CHOP. Single agent doxorubicin, which is every 3 weeks for 5 doses. Pretty good response rate. Doesn't quite make that 10 to 12 months though, only 4 to 6 months in terms of the response duration. CHOP is just CHOP without the doxorubicin. It's sometimes weekly in the beginning, but the owner, the practice doesn't have to take on the risk of the doxorubicin toxicities. So that's one of the reasons that people that do CHOP really like to do CHOP. Again, compared to CHOP, the response rate's a bit less, shorter duration. If you do CHOP and it stops working, and then you do doxorubicin, you can kind of get an equivalent outcome to CHOP. But then you've kind of sort of done CHOP, just in a different order. And then I mentioned CCNU. Its big advantage is that it's oral. So if you don't want to have to handle injectable chemotherapy in your practice or worry about extravasation risk, it's a nice option. It's every 3 to 4 weeks. It has some pretty significant toxicities that you need to be aware of. It's rather myelosuppressive, and it can cause liver failure if you don't monitor their liver enzymes closely and stop if their liver enzymes are elevating. Its efficacy is not that well defined. The response rate's around 50%, which isn't too bad, but it's only about 40 days. So overall, doesn't quite seem to be as promising as single agent doxorubicin or COP. Okay, I think this is what I wanted to point out when we think about injectable chemotherapy or CHOP. We think about that for the high-grade large cell lymphomas. There are a few situations where it's probably not the best thing. So that is the small cell low-grade GI lymphoma, which a lot of people are used to treating cats for, but dogs can get it as well. If they have a chronic lymphocytic leukemia, if they have a T-zone lymphoma. For some cutaneous lymphomas, CCNU seems to be more successful than CHOP. And there's some data out there that T-cell lymphomas might do better with alkylating agent protocols rather than CHOP. Okay, I have two case examples, and then I'll talk about Tenovia and Laverdia. So the first example is a 2.5-year-old male castrated boxer, a very young dog, not expecting to have cancer, but young dogs get cancer. He initially presented for lethargy and inappetence. He had vomited a lot after drinking some water. He had a history of dietary indiscretion. So initially just some supportive GI meds were prescribed. He didn't get any better. So 4 days later, they did some blood work. He had a azotemia with a BUN of 36, creatinine of 2.4, a very high calcium at 14, and then a high phosphorus. He was treated with fluid therapy and IV antibiotics, didn't get any better, came to our ER. So after 2 days of fluids, let's see, he's lethargic, hypersalivating, he's hypertensive, and after 2 days of fluids, his values are even worse. BUN of 78, creatinine of 5.7, calcium up to 17, phosphorus still high. So the emergency clinician is worried about acute renal failure and wants to image the kidneys. As an oncologist, anytime we hear high calcium like that, we're worried about lymphoma. So he got, imaged and worked up on a hunt for cancer, even though he was a young dog. And here's his thoracic radiographs. He has this mediastinal mass or sternal lymphadenopathy. This is what it looks like on ultrasound. He has some more diagnostics done. His kidneys were actually okay, did not seem to be involved ultrasonographically, but he had aspirates of various organs done, and we found lymphoma in his mediastinum, his spleen, and his bone marrow. And immunocytochemistry is what we did for phenotyping, and it was confirmed to be T-cell, which is what we would have predicted based on the hypercalcemia, the mediastinal mass, and the boxer. So he started CHOP chemotherapy. He stayed in the hospital for about 5 days. As he started the chemo, he got, continued to get fluid therapy, GI meds, some antibiotics, blood pressure medicines, and a phosphate binder. By day 5, his ionized calcium had normalized. He remained azotemic, ultimately was discharged on sub-Q fluids. So ultimately, he went through a 6-month CHOP protocol that included CCNU to get him some alkylating agents, as well as an oral chemotherapy drug called procarbazine. He remained hypertensive, but was managed with medications. He had recurrent UTIs, and his renal azotemia got better over time, but never fully resolved. So, he's going to be a stage 5. He had it in his bone marrow with the mediastinal mass. He's going to be substage B, and he's T-cell. So he has all the negative prognostic factors. Plus he had, renal injury from his hypercalcemia. But he was in remission over 2 years from his initial diagnosis. And I don't have the full follow-up listed, but I think he lived to be a middle-aged to older dog and ultimately passed away from progression of his renal disease. His lymphoma never came back. So success story, in my opinion. This other case, also a happy ending. 7-year-old female spayed miniature pinscher. She came in for multicentric lymphadenopathy. So palpating her lymph nodes, you'd be like, yep, that's a high-grade large cell lymphoma. But on cytology, she didn't have large cells or blasts. It was diagnosed only as lymphoid hyperplasia. She did have staging tests. On her blood work, she had 40,000 circulating lymphocytes, but no cytopenias, and they were small, mature lymphocytes, not blasts. Her spleen was modeled on her imaging, and because of the circulating cells, she had a bone marrow aspirate that also had those same cells present. Her rickettsial disease testing was negative. So she actually had lymph node excision and histopathology. And on her lymph node histopathology, she was diagnosed with indolent T-zone lymphoma. And this is not her, but Peeper on indolent T-zone lymphoma and how to classify it. There's an H&E image on the left showing what the lymph node looks like histologically. And then these are the abnormal where the neoplastic cells are, and those are all CD3 positive, so T cells. And then the B cells are out here at the periphery. So you can diagnose this with histopath or flow cytometry, and there's specific markers that the T cells express on flow cytometry with T-zone lymphoma. So this is, I think people these days are getting pretty good about recognizing this as a form of lymphoma. The cells are small, they're not blastic at all, and really to know whether the architecture of the lymph node is abnormal or if it's just a reactive process, you really need the histology or flow cytometry. There was a case series, about 40 cases published back in 2013, and those dogs had median survival times of 33.5 months, so almost 3 years. And whether they got treated, what type of protocol they got treated with did not seem to affect their outcome. So it's called indolent lymphoma because it has a very indolent, slowly progressive clinical course. It's called T-zone lymphoma because the neoplastic T cells come from the paracortical T-zone in the lymph node. So this dog, she actually did not pursue any therapy. She was monitored with physical exam and CBC, and she had stable disease for at least 2 years without any intervention whatsoever. So that's my sort of whirlwind review of lymphoma. And again, one of the main points I want to make is we use the word lymphoma, but it's a lot of different types of diseases. It can have a very different clinical presentation and a very variable clinical course. So we always think about what's happening in the specific patient that we're working with and try to tailor the treatment plan to them. Okay, so now I'm going to talk about the 2 novel drugs that are available for dogs. So all the chemo drugs I've talked about so far are drugs approved for use in people that we use off-label in dogs. So these are drugs that were developed and marketed specifically for dogs. Laverdia as a class of drugs has some similarities to some drugs in people that I'll mention. Tenovia was developed by VetDC and is now, I think, distributed by Elanco, and Laverdia was developed by Anaviv and is distributed by Decra. Okay, so Tenovia came out first. That's why I'm going to go through it first. The chemical name or the generic name is rabaxifosine. Then there's the preclinical pharmaceutical compounds listed there. And then there's this very long chemical name that I'm not going to try to pronounce. So we usually call it Tenovia because that's the easiest to say. It's a classic chemo. I think of it as a classic chemotherapy, an anti-metabolite. It's in the family of drugs. It's called an acyclic nucleotide phosphonate. Nucleotides are the building blocks of DNA. And so what Tenovia does is it inhibits DNA polymerase. So before we had Tenovia as a clinical drug to use, the compound that was investigated is PMEG, phosphonyl methyl oxyethyl guanine. And that guanine there hopefully brings you back to thinking about DNA and your DNA bases. So in cells, this PMEG drug is phosphorylated to PMEG diphosphate, PMEG-PP. And that's an analog of deoxyguanine triphosphate, which that's sort of the building block, the nucleotide of the DNA. So that analog, or that GTP analog, p-MEG diphosphate, inhibits DNA polymerases. And you need DNA polymerases to both synthesize and repair DNA. So if your DNA polymerases don't work, you're ultimately going to have cytotoxicity. I promise we'll get back to how we come back to Tanovea in a second. Okay, so the problem with that p-MEG compound, even though it had really good efficacy against leukemia and melanoma in rodent models, it didn't get into cells very well, and it had a fair bit of kidney and gastrointestinal toxicity. So what they did in the lab was develop prodrug analogs that would get into cells better and have some more selectivity for the organs and cells they were infiltrating. So what the scientists did is they screened these prodrugs for ones that would infiltrate peripheral blood mononuclear cells, that includes your lymphocytes, with the active form, the p-MEG diphosphate. So that would get in the cells, but not be in the circulating plasma. And the analog that sort of met their criteria was this GS9219 that eventually becomes Tanovea. So this is histology from normal beagle dogs that received a vehicle control, the analog, and the p-MEG product itself. And just looking at the representative histology here, you can see that with the GS9219, you have much less toxicity on the kidney and the GI tract, but still get effects in the lymph node. So this is the first study that was published in dogs with the GS9219, looking at it in lymphoma. It's a phase 1 study where they're looking at different dosages and different schedules to try to understand efficacy and toxicity. So what comes out of this is a sense of what the toxicities are. And the 3 main ones that came out of the study were some side effects in the skin, GI upset with anorexia and diarrhea, and neutropenia. So the GI and neutropenia is pretty common for a chemotherapy drug, not surprising there, again, because that the way the drugs work is going to impact your rapidly dividing cells in your bone marrow and your GI tract. 37% of dogs did have the dermatologic toxicity, which is an uncommon thing that we see with chemotherapy drugs. But in this first study, that seemed to be in the daily and weekly cohorts. So the studies going forward are every 3 weeks, not daily or weekly. And then importantly, 2 dogs had pulmonary adverse events and a necropsy that was confirmed to be fibrosis in 1 dog. Okay, this is the pharmacokinetics that they did on the dogs. And I just will point out here, there's the p-MEG, here is the compound they're administering. And when you look at levels in the plasma, you don't have very high levels of the p-MEG in the plasma, but you do have high levels in those peripheral blood mononuclear cells. In terms of efficacy of the dogs in this cohort that are reported, 21 had prior chemo, 17 were treated in the naive setting, and they had a pretty good response rate, 61% CR, 18% PR. And when they looked at length of remission for the dogs with B-cell, it was 132 days, and then very poor in the dogs with T-cell lymphoma, only 14 days. So that's going to be a recurring theme with Tanovea, that it works much better for B-cell than T-cell lymphoma, which is one of the reasons to do the immunophenotyping. Okay, so that's the phase 1 study. They moved forward with additional work and ultimately came up with a label for lymphoma in dogs. That's 1 mg per kg over 30 minutes, every 3 weeks, up to 5 doses. Because of the pulmonary fibrosis concern, it's labeled as not to give in Westies dogs with pulmonary fibrosis or dogs with other chronic pulmonary diseases. And certainly we recommend taking chest films before treating dogs with Tanovea. This is the data in the package insert for 22 dogs. A little bit different than from the published study, but an overall response rate of 77%, 134 days median progression-free survival. More efficacious in naive dogs than pretreated dogs. That's not surprising. And then the side effects I mentioned, and again, better in B-cell than T-cell. So since that time, there has been a lot more research done with Tenofovir. And this is the largest study published that I'm aware of. It's 120 dogs that got Tenofovir versus placebo-controlled. So this was the pivotal study to get their full FDA approval. And in the dogs that got Tenofovir, the overall response rate 73% compared to 6% in the placebo. 82 days progression-free survival compared to 21 days in the placebo. These numbers maybe don't sound as good as what I had on the other slide, but there's 50% naive and 50% previously treated. So they're pretty good numbers given the high proportion of previously treated dogs. Specifically looking at the dogs that got Tenofovir, again, the B-cell dogs had much better progression-free survival than the T-cell dogs. Here's the GI signs as the main side effects. Overall, pretty mild. And then again, this idiosyncratic pulmonary fibrosis in some dogs. There is a paper where they grouped a bunch of different studies looking at dogs with Tenofovir in the naive setting. So not having the mix of naive and previously treated. And that's got about a 90% overall response rate. Again, much better in B cell than T cell. And again, still the pulmonary fibrosis concern. And then 3 more protocols with Tenofovir to just mention. Because it can be given every 3 weeks and it doesn't have cardiotoxicity, there is some interest to try to combine it with doxorubicin so that you can give some doxorubicin, but not enough doxorubicin that you worry about effects on the heart. So this was looking at alternating Tenofovir and doxorubicin every 3 weeks. Again, pretty good overall response rate, reasonable progression-free interval, still had skin side effects, still had some pulmonary fibrosis, even though they're only getting 3 doses of Tenofovir in this particular protocol. For cutaneous T-cell lymphoma, so you remember that I harped about it was better in B-cell than T-cell for all the different Tenofovir studies. The exception might be for cutaneous lymphoma, and that's again because the drug seems to concentrate in the skin and have the skin side effects. So the overall response rate, however, wasn't that great, only about 45% and not a very good progression-free survival. And then they've also looked at it for multiple myeloma, has a pretty good overall response rate, reasonable progression-free interval, still dogs dying of pulmonary fibrosis. This is not as long of a progression-free interval as I think we get with melphalan and prednisone, but if you have a dog that's difficult to medicate, like the owners can't pill it, this might be a good alternative. Or if they're having, they're not tolerating the melphalan due to myelosuppression, the Tenofovir might be a good option. Okay. And I just wanted to mention another rare adverse event that can happen with Tenofovir. You might remember I said in the beginning, there was kidney toxicity from the PMEG component. And so in some of the Tenofovir dogs, very rare, like less common than the pulmonary fibrosis, they did develop Fanconi syndrome. So it's not a very common side effect, but worth keeping an eye on their UAs to monitor for glucosuria. Okay, that's what I have for Tenofovir. I'm doing okay on time. Next, I'm going to talk about Laverdia. And this has the CA1 on there to indicate that it's a conditionally approved drug. And that means to use it in practice, you have to use it strictly according to the label. So its drug name is Verdinexor. And it is not a classic chemotherapy. I think of it as a targeted therapy because it's not causing non-specific DNA damage to the cells. It's trying to target a specific pathway. It's Karyopharmaceuticals that originally developed it. So any drug that you read about that starts with KPT is probably in the same class of drugs. And that's called the SINE class, Selective Inhibitor of Nuclear Export. This particular drug inhibits XPO1, which is a protein that binds or transports other things in and out of the nucleus. So by inhibiting that transport protein, we're hoping to keep tumor suppressor proteins in the nucleus to do their thing. And the human SINE drug that's out there is called selinexor. And this is just a little schematic showing here's XPO1 in the nucleus where it can have various cargoes that it transfers out of the nucleus. And with the sign drug bound, you keep that transport protein in the nucleus and therefore keep the cargo in the nucleus as well. So this is the first phase 1 study here with Laverdia KPT 335. They had 2 different cohorts of dogs with lymphoma, one where they got sort of different dosages of the Laverdia, and then an expanded cohort where they all got the same dose. They did not have any CRs, just PR or stable disease. And the median time to progression, depending on which cohort you're looking at, was 66 or 83 days. And there's their length of response. So then they did a phase 2 study once they had a dosing regimen established. So this is the data from the phase 2 study. This is the time to progression in the different groups of dogs and the number of dogs that responded. So it's broken down into naive B, naive T, or relapse B or relapse T cell. So not very long time to progression here. And overall, not a very great objective response. So only about a 35% response rate, not as high as Tenovia. Interestingly, though, it seemed to work as well in the naive dogs as the relapse dogs. And they actually did a little bit better in T cell dogs compared to B cell. At least half the dogs on the study did receive prednisone, though. So one of the challenging things to understand that I don't think we fully understand about Laverdia is if it has any better efficacy than pred, and particularly given here, some of the dogs also received pred. In terms of side effects, the first 3 things here are from the drug insert. It says it can cause severe anorexia, dogs should be carefully monitored, and that it can cause hematologic and serum chemistry abnormalities. So, you might sort of go, oh, it's not traditional chemotherapy, maybe it's better tolerated, doesn't have the same degree of side effects. And that's not necessarily the case. I think it doesn't have the risk for a profound neutropenia in nadir like the chemo drugs can have, but it can still have some abnormalities. In the phase 2 study, which was 58 dogs, all dogs had some sort of adverse event, generally mild, but there was some anorexia, there was some thrombocytopenia, there was some leukopenia, but it wasn't severe. So like I said, it's not clear that this has better outcomes than prednisone, and Anaviv does have placebo-controlled trials that are underway right now. Okay, so in the last few minutes, I wanted to talk about kind of a different approach to thinking about lymphoma and how to help dogs with lymphoma, and that's to think about drug repurposing. So, I just spent 45 minutes talking about lymphoma. It's one of the most common cancers in dogs, but actually, to try to understand how many dogs get lymphoma is a little challenging. We don't have great registries. So I kind of pieced together data from conservative estimates, data from some insurance breed registries in Europe, data in high-risk breeds. And so it's probably somewhere between 3% to 14% of all dogs get lymphoma. And if you do the math worldwide, that means 40 million dogs. So that's a lot of dogs. Okay, we know a lot of dogs get lymphoma, but how many dogs with lymphoma really get treated? And that's a question I would love to know the answer to. I personally, based on the number of phone calls I get and the number of cases that we see in the clinic, think that there's probably at least 50% of all dogs with lymphoma, okay, so that would be 20 million dogs, that never see a specialist. And maybe they're getting treatment without seeing a specialist, but probably many of them aren't. Even the dogs that do go see a specialist, not very many of them get chemotherapy. A little more than half get chemotherapy. So I'm, really interested to understand why these dogs don't get treated, because that's a huge population of dogs that we could try to help. So this is, my thoughts on what are the hurdles to care, why dogs don't get treated. And the first group I think of as access to care. And some of that is geography, some of it is financial, and some of it is availability. So this top map is where, if you go to vetspecialist.com, where oncologists are in the US. So you can see, right, there's a whole lot, my pointer comes back, a whole lot on the East Coast, here up north, right? But there's this huge swath of the country that doesn't have an oncologist. So it seems pretty challenging to go see an oncologist in those areas. These dots, the map below, are the COTC sites. That's the funded clinical trials through the NCI. And you can see the pattern follows really as where the oncologists are. Pretty good on the coast, pretty good in the north, and then it's sort of a barren desert. Okay, so trying to find someone that's comfortable treating their dog can be a challenge. Obviously, it's a lot of treatments. It can be very expensive. And then, maybe they have all the money in the world and an oncologist down the street, but the oncologist down the street doesn't have an appointment available for 2 months. And a lot of dogs are going to die from their lymphoma before then. So I think about access to care. And then again, even with access to care, there are a lot of families that don't want to do chemotherapy. And that is concerns about toxicity, but also travel back and forth on the dog, the impact on the family, and then the impact on household exposure. So I am interested to understand, what can we do to help those dogs that can't get chemotherapy for whatever reason? Right now, we pretty much just have prednisone and symptomatic care to offer those dogs. And this is a relatively recent study just looking at dogs, again, with nodal large cell lymphoma that got prednisone alone. And the median overall survival time was 50 days. So, not great. Interestingly here, the T cell dogs did better than the B cell dogs. So, what's available on the market to try to help dogs other than chemo right now is Laverdia, which we just talked about. And again, it's not very clear that that is any different than prednisone in terms of the impact on the dog. Laverdia is a lot more expensive, has a lot more side effects than the prednisone. So I was approached about investigating doxycycline as an agent for lymphoma. And this was from some researchers out of the University of Rochester at Strong. And they identified doxycycline as a drug that had the ability to inhibit NF-kappa B signaling, which is a pathway important in lymphoma. So I just have a little bit of preclinical data that I won't spend a lot of time on, but they did a lot of work to show that doxycycline can inhibit pathways that are important in lymphoma. One of those pathways is the NF-kappa B pathway. So this is lymphoma cell lines showing that doxycycline can inhibit that pathway. Then this is actually smooth muscle cells looking at MMP9 activity and showing that doxycycline inhibits MMP9 activity. That's matrix metalloproteinase 9, and that's another enzyme that's important in lymphoma and lymphoma progression. So then they did some work with rodent models and xenografts. So this is looking at either cell lines, lymphoma cell lines injected into mice, or lymphoma cells from patients injected into mice and the impact of doxycycline. So you can see here with increasing concentrations of doxycycline, there's less proliferation. And these are mice that got vehicle control, and dox here is doxycycline, not doxorubicin. They had a slower growth rate compared to the control mice. So I said, yeah, let's see if we can figure it out. One of the things I thought was most attractive about doxycycline is it's inexpensive. It has a known toxicity profile in dogs, and it's widely available. So it's not something that would, if it worked, would be on patent for a really long time or would be really expensive. So the initial assessment that we did in dogs with nodal lymphoma was first to, again, just do some cell line studies. So this is dog lymphoma cell lines, and then primary lymphoma cells from 4 different dogs, increasing concentrations of doxycycline, and we see less proliferation in the cells exposed to doxycycline. Then we gave dogs with lymphoma doxycycline to see if we got any responses, and we looked at their serum levels of doxycycline that we were able to achieve in their blood to see if we could get the levels that had the in vitro effect. So this is showing pretty high doses, 10 mg per kg or 7.5 mg per kg. Over here, we're sort of trying to get around 6 micrograms per mil, which is about here. So we were able to achieve that with these high doses. The dogs did not have regression of their lymph nodes, but we did have, in the small number of dogs that we looked at, have stable disease for a period of time. So we thought that was encouraging enough to combine it with prednisone and see what happened. So these are the data from a randomized controlled trial that we did. It's just in text format or graph format. So we had 6 dogs that got prednisone alone, 10 dogs that got prednisone and doxycycline, and then we had 3 dogs that got prednisone and Laverdia. So this red line is the survival in the prednisone and doxycycline dogs, and they did much better than the other 2 groups. And here's their median survival time. So we, in our prednisone alone, 60 days, very small number of dogs, but pretty similar to the 50 days from the other study. And then our doxycycline prednisone dogs, our median was 116 days, so almost twice as good. In terms of how they tolerated it, their body weights were stable. Only 1 dog was withdrawn for quality of life concerns. That owner happened to live 5 hours away. We didn't really have any significant hematologic toxicity. 1 dog did have mild thrombocytopenia, which may have been related to his lymphoma. We put his pred back up to daily and that normalized. The main side effect that we saw was liver enzyme elevations 1 week after starting the doxycycline and the steroid in 4 dogs. None of them had clinical signs of illness. And it was really in the dogs that received a relatively high dose. Only 1 of 7 dogs that received less than 6 mg per kg. We treated with the drug holiday or denamarin. They got better within a couple of weeks and were able to go on a reduced dose of doxycycline. And there was no impact in terms of that toxicity if it impacted their survival time. So to me, it seems an encouraging thing to consider for dogs that don't want to do chemotherapy. So if somebody wants to try this, we would recommend 5 mg per kg twice a day. We gave them concurrent metoclopramide. And if you had a small dog, I might try the doxycycline just every 24 hours. We recommend checking their blood work to see what their liver values are doing at that 1 week after starting the protocol. But if they didn't have elevations week 1, we followed them for at least 12 weeks. They did not have elevations in the future. So really don't have to check them that frequently. Just that first week is really important. And that's the prednisone dose that we did, once a day for 7 days, then every other day. So what we're would like to do now is try to figure out a way to work with folks in general practice to sort of understand what your experience or their experience with lymphoma is like and how the dogs are doing. And then we have an open trial looking at doxycycline with oral cyclophosphamide, with the hope that ultimately it could be a low-cost tolerated protocol to think about in practice. And we're enrolling dogs with nodal lymphoma or cutaneous lymphoma. And then we want to try to understand what effects the doxycycline is having in those dogs. And as I said, here's the picture of current Ziva, 14 now. And that means I'm ready to stop talking. I did want to highlight the current clinical trials that we have open. We have them for dogs with lymphoma, dogs with oral squamous cell carcinoma, osteosarcoma, and hemangiosarcoma. And you can email, this will get you to the clinical trials coordinators, or you're welcome to ask me as well. So thanks very much for your attention. Ooh, 2 minutes short of 7. I'm happy to answer questions. If you have any. Ashley, should they type in chat or? Yes,
They can do either. Oh, there's one. The question is, any trials with biologics?
Yeah, so in terms of thinking about, I don't know if you had a specific biologic in mind, but we don't have any trials here with a monoclonal antibody or a vaccine. You know, people think about those trials are aimed at, you know, sort of harnessing the immune system to help fight cancer. And actually cyclophosphamide is a drug that has been used as immunotherapy for a long time. So that's the closest I have to offer you for immunotherapy, is the trial does have cyclophosphamide in it. It looks like the chat isn't working, but you can type a question in the Q&A if there are other questions.
Next question. Do you have any recommendations on early detection? I find patients are getting their dog's diagnosis once it has progressed to a further stage.
Yeah, so that's a really good question. I think one of the challenges with large cell lymphoma is it's very rapidly progressive. Like you could sort of have, oh, I'm not sure if the lymph nodes are big. And then 2 days later, they're ginormous. So, I don't think it's hard for me to know how long dogs are living with their disease before they're diagnosed. But I think to catch lymphoma early, you'd have to be screening so frequently just because of how rapidly progressive it is. So, I mean, my general recommendations to dog owners are sort of, knowing where the lymph nodes are in your dog. So the ones you can feel are the ones under the chin, in front of the shoulders, and behind the knees, just so that if you happen to notice that's abnormal, you'll pick that up hopefully before your dog starts to have clinical signs. Okay, if possible, would you go with CHOP or L-CHOP? So that's asking about whether to combine L-asparaginase with CHOP. L-asparaginase is a compounded medication. It's not commercially available. So depending on where you live in the US and what regulations your veterinarian has to follow, it may be easy to get L-asparaginase, or it might be challenging. There are 2 studies that looked at combining L-asparaginase with chemotherapy for lymphoma, and there was no difference in response rate or outcome between dogs that got L-asparaginase or that didn't. What's nice about L-asparaginase is it's reasonably well tolerated. It doesn't really have GI side effects or myelosuppression. So if your patient or your dog is sick from lymphoma, it's sometimes nice to give them a chemotherapy that doesn't have GI side effects as you start to treat the lymphoma. So I think it is helpful in certain scenarios, but I don't think that it's essential if you're going to do CHOP or L-CHOP. Okay, and the next question was comment again about synovia and renal function effects. So most dogs do not have any renal side effects or acute kidney injury like we think happens, or like that case I went through had with hypercalcemia, but it can cause some damage such that Fanconi syndrome develops. And the first sign of that is usually glucosuria. So just sort of, I think, we're used to monitoring their blood work in terms of looking at their CBCs, but I think it's probably a good idea just to collect a urine sample every couple of doses. And with that Fanconi syndrome, what's happening is they're losing glucose and protein in their urine. I think there's a question sort of about age of the dog and treatment. It's not so much age, but how your dog's quality of life is, and if there's any comorbidities of systemic health. So I think, with blood work and a conversation with your veterinarian, you can have a good discussion about that. Thank you, Rachel, for your nice comment. Any other questions?
Looks like there's one more there, Kelly.
About genetic testing. I'm not sure if this question is thinking about like Vidium and PhytoCure to look for mutations that might be present in the lymphoma. I am not aware of data suggesting that would help choose any of the therapies that we know the most about. So there's, like if you think about, I'll use a mast cell tumor as an example. The dogs that have a KIT mutation might respond to a drug that targets the KIT protein. So you could test your dog's mast cell tumor for that mutation and then say, okay, I'm going to use the drug that targets that. But these therapies that we have the most efficacy for lymphoma are relatively nonspecific and not based on whether there's a specific mutation present in the lymphoma. I think, one day we might have that information, and there's certainly some reasons to think about doing that in people where they have specific chromosomal translocations that could be targeted with drugs, but I don't think that is ready for prime time in dogs yet. All right, well, I'll let everyone go enjoy the rest of their evening. Thanks again for your participation. If something comes up, feel free to reach out via email.